Dear colleagues, this case is a 54-year-old male patient presenting with severe lower urinary tract symptoms, and we scheduled this patient for a MILEP procedure, and the prostate size was 51 milliliter. We first check the urethra and the urinary orifices, and the bladder neck is quite high and it's very narrow, so the patient has severe obstruction. And in this case, first we start with incising the mucosa around the vermontanum. This is an inverted U incision for the mucosa in order to detach the adenoma from the capsule. So we start with this incision because this is the place where the adenoma is very thin and we can reach the capsule very easily. So after completion of the incision, then the next step is to develop the perfect enucleation plane. Unfortunately, in these small size glands, we usually cannot see the very beautiful plane, but with the help of the holmium laser's high peak power, it's possible to reach the capsule easily. So after doing the incision, I just turn my resectoscope, my working element upside down so that the laser fiber is now going out from the 12 o'clock position. And I am continuing with my dissection in the posterior part. This is just to advance the enucleation plane a little bit posteriorly so that we will be able to see the apex, the anterior part easily, and we can do the early apical release in a beautiful way. So in this surgery, our laser settings are for the enucleation 2.5 joules of energy and 40 hertz of frequency. And for the coagulation, I'm going to use 1 joule of energy. So again, I check the place of the sphincter and it's really very close by at the apex because it's a small gland. So now I'm doing the apical release and now incising the mucosa at the apex. So at this point, I'm also incising a little bit into the adenoma intentionally because otherwise the sphincter is very close. So I don't want to give any harm to the mucosa of the sphincter. So also the angle is very acute in here towards the anterior side so that I'm again using my laser fiber at the 12 o'clock position. So after doing some mucosal incision, now the tension on the sphincter is released. So I continue more on the posterior and the lateral side of the prostate. So after doing some posterior dissection, now again turning to the lateral side. And with the help of the high peak power of the holmium, the dissection is possible. And at the same time, here with the help of the high energy setting with 2.5 joules and also applying it with a long pulse duration, the photothermal effect of the laser is also very prominent. And as you can see, there is almost no bleeders where I fire the laser. So I do not need to use my coagulation setting at all. I'm just continuing with my 2.5 joule enucleation parameter. So now I further try to dissect the apex, and while doing that, you can see that the area of the sphincter is very close by. So I check it regularly, and now I'm trying to advance my plane from lateral to the anterior in order to detach the adenoma completely. So at this step, I somehow incise into the adenoma. Because otherwise the risk of damaging the sphincter is much higher. And also on the right side of the apex, I'm trying to do some anterior dissection in here. And it's really important to balance, to be a little bit away from the sphincter, but at the same time not to leave a lot of tissue, because otherwise the risk of regrowth of the adenoma is high. So here the idea is to enucleate as much tissue as possible, but at the same time try to stay a little bit away from the sphincter. Because in the end, the early postoperative incontinence is the most problematic complication of the HoLEP usually. So here now I'm trying to connect the plane anteriorly coming from both sides. And once these two enucleation planes are connected, then the rest of the surgery is usually much easier. And as I mentioned, really the photothermal effect of the laser is also very good, so that we almost have no bleeders. So one point for discussion is in these small glands, of course, a TURP can also be performed. However, I think HoLEP is also a very good alternative for the management of these smaller glands, because in the end, we can do the surgery much faster, and more importantly, in order to do an effective resection, we usually need a 26 French resectoscope. But here in this surgery, I'm working with the 22 French resectoscope, so it's quite friendly with the urethra. The risk of urethral damage is very low, and at the same time, the duration of the surgery is much shorter compared to a TURP because the entire enucleation time for the surgery is less than 12 minutes. However, in order to do a good resection, it would probably take a longer time, and by the effect of the electrocautery, the risk of the urethral injury may be higher. So now I continue the enucleation En-Bloc all over the prostate. This is the left side of the prostate, then we turn to the anterior, and now I'm going to the opposite side, 10 o'clock, 9 o'clock, again back, 11 o'clock, 12 o'clock, 1 o'clock. So at this step, I'm doing some anterior dissection in order to reach the bladder. So one of the most important advantages of the En-Bloc technique is also as we keep the adenoma inside the capsule and during the entire enucleation, while we are working on one side of the prostate, we can also apply some tamponade, but with the help of this adenoma to the other side so that the amount of bleeding is less. So as I mentioned, these smaller prostates are not so good for a good enucleation plane. That's why I really like holmium laser for those cases, because in the end, with the help of the high peak power, we can see where we treat or where we enucleate. And here we already reached the bladder from the anterior side. So this is another advantage of the En-Bloc technique, because you can enter the bladder from the anterior side, so that during the first entry, the risk of urethral orifice injury is almost zero. And now we reach the bladder on between 2 o'clock and 11 o'clock. So now I'm incising the bladder neck more from anterior to lateral. And by this way, we will have a better orientation for reaching the bladder. And here I'm using my resectoscope by turning the laser fiber a little bit from 12 o'clock down to 6 o'clock, because the prostate has a round structure. It's a global organ. It's a global adenoma. So by this way, I can follow the anatomical curve of the prostate, because at this step, especially in the smaller glands like this with a high bladder neck, there is always a risk of undermining the trigone, so we can go posterior to the bladder, so we don't want that. That's why I'm incising the bladder neck more and try to connect this opening, this reference line coming from the bladder neck, with my posterior enucleation point. And as you can see, I'm now keeping my fiber on the anterior side of the screen so that I can fire more towards the adenoma. This is quite important because, as you can see, the adenoma has some extension under the trigone. So if I go a little bit more deeper, just a few millimeters, this plane will definitely take me to a posterior perforation plane. So here the idea is just to connect this posterior enucleation plane to the other reference point that comes from the bladder on 5 o'clock and 7 o'clock. And I'm also cutting a little bit of the adenoma by firing towards the adenoma. This is intentional because otherwise there will be really the risk of injuring the posterior plane. So again, I'm firing more towards the adenoma, and now it's time to connect this with the lateral reference coming from the 4 o'clock or 5 o'clock position at the bladder neck. So at this step, if you have any difficulties, there is always a chance to make an incision at the 5 o'clock inside the prostate so that you can have a much better orientation. But as you can see, I'm firing more into the adenoma here because you see really the enucleation plane is not so beautiful. It's not enucleating very easily. So as you can see, if I just go a few millimeters deeper, then there will be a risk. And these are the final attachments at the bladder neck. And I further continue just to cut those mucosal attachments, and the enucleation will be completed. So the entire gland is now pushed into the bladder, and we are checking the sphincter. It looks very good. And this is our entire fossa. So in less than 12 minutes, the entire enucleation is completed, and the morcellation part of the surgery just takes less than 5 minutes. And by this way, the entire surgery, including coagulation, takes only less than 20 minutes. So this is a video just to explain why MILEP or HoLEP or laser enucleation of the prostate is a good alternative for the management of the smaller prostates as well. Thank you.